Good afternoon, everyone, and welcome to today's Launching into Telehealth session. Overview of current federal and state telehealth policy. Today is Friday, July 10th, and this session will be going from 1 o'clock p.m. to 2 o'clock p.m. Eastern Time. Today we have our single panelist who is the star for today's session, Mei Kwong, who is the Executive Director for the Center of Connected Health Policy. And since she is the only panelist, and I am her project officer for the Telehealth Resource Center program at HRSA, I would actually like to introduce Mei with her bio. So Mei Kwong has over 2 decades of experience in state and federal policy. She is the Executive Director for the Center for Connected Health Policy, the federally designated National Telehealth Resource Center. She's written numerous policy briefs, crafted state legislation, and led several coalition efforts on a variety of issues. She has published articles on telehealth policy, is a recognized expert in her field, and has been consulted by state and federal lawmakers on telehealth legislation and policy. Mei Kwong is a graduate of the George Washington University Law School. Just a few reminders for folks. So you have a couple options when submitting comments, and we do encourage you to ask comments, but please be nice as we only have one person plus potentially myself to help answer questions. But you could submit comments through the Event Mobi app that you have, and also through the Zoom chat. And so we'll do our best at the very end to answer your questions. But without further ado, I will go ahead and turn it over to Mei. Thanks, Mei.
Thank you, Natasha. Thank you. And thank you also to the Northeast Telehealth Resource Center and the Mid-Atlantic Telehealth Resource Center for inviting me today. And thank you all for attending. So before we get started, I always have to start off with a couple of disclaimers. So any information I provide today should not be considered legal advice. It is strictly for informational purposes. CCHP always recommends that if you are interested in a formal legal opinion, that you consult with legal counsel. Also, if I happen to mention a company or show some sort of product, know that neither I nor CCHP has any type of financial arrangement or relationship or interest with such a company. So a little bit of information about CCHP. We were established in 2009 as a California telehealth policy organization underneath the Public Health Institute, but we became the federally designated National Telehealth Policy Resource Center through a grant from HRSA in 2012, and we've been working in that capacity ever since. We also work with a variety of funders and partners too on various projects related to telehealth or connected health. Some of the projects we work on, we do a 50-state telehealth policy report of all of the Medicaid policies, laws, and regulations for all 50 states in the District of Columbia. We also tracked federal legislation as well, for those who may be wondering about that. We also act as an administrator for the National Consortium Telehealth Resource Center, and I'll explain that in a moment. And we are convener for a group in California called the California Telehealth Policy Coalition. So the National Consortium of Telehealth Resource Centers are the 14 telehealth resource centers who all have a grant through HRSA underneath the same grant program. What this means is that there are 14 of us, 2 are national centers. CCHP is the one on policy, and the other national center focuses in on technology. They're based out of Alaska. And then there are 12 regional resource centers that cover specific states. The hosts for today's webinar and conference are the Mid-Atlantic and Northeast Telehealth Resource Centers. And we all work pretty collaboratively together. So even though you may not be in somebody's region, if you reach out to that telehealth resource center, they'll make sure you get connected with your regional representative, as well as connecting you with everybody else to answer your questions. So as we say, we work very collaboratively together. That's to make sure that we're not duplicating efforts, that we have a consistency of message. So I like to say you reach out to one of us, you'll actually get all 14 of us. I mentioned our 50-state report. This is actually a snapshot of our website, which houses the report in 2 formats, a PDF file as well as the interactive map, and this is the interactive map version. So we update that information twice a year. As you can imagine, it's it's a pretty involved process if you're looking at all 50 states and the District of Columbia, and if you're looking at laws and statutes and Medicaid program policies. But that information needs to be kept up to date because it can change fairly frequently and rapidly depending on, what the states are doing at that time. So we do update it twice a year in the spring and in the fall. And actually, we were in the midst of our spring update when COVID-19 hit. So we do have the information updated for the spring. The information on our website is good through 2020 of February. But it does not contain the COVID information. That is actually housed on a separate section of our website because a lot of the COVID telehealth policy changes were temporary, they were based on waivers. So the 50 state information is the more permanent changes. Now we do track changes through legislation and bills that are going through the state process on our website as well, and some of that has been including some of the COVID changes to make them permanent, and I'll explain a little bit about that later. That can also be accessed through this website as well. And that information is kept a little up to date more regularly because we follow the bills and regulation as they go through the process. So I'm sure I'm not saying anything new or that none of you have experienced or understood yourself, but COVID-19 not only has really changed our lives in general, but really has dramatically changed the landscape for telehealth in a lot of respects, not only just with policy, but in just its everyday utilization and in how healthcare providers now provide services. So it's had this phenomenal effect on telehealth and raising its profile and having people understand and be more educated and aware that this exists out there. But that's what's also come with that were a lot of policy changes as well, because pre-COVID-19, there were some policies that would inhibit its use, act as a barrier, recognizing that telehealth could be an extremely valuable tool during COVID, and especially with a lot of people sheltering in place at home, but still needing to get healthcare services, these policy obstacles needed to at least be relaxed temporarily in order for people to access those services. So the way I've broken out this presentation is there's a federal section and a state section, and we'll be going into detail for both of them. Now, what I am presenting to you may look like it's extremely detailed, it's a lot of things, a lot of nuance changes. It's still fairly high level because the way telehealth policy is, I liken it to an onion. You sort of peel away like one policy element and then there's like all these other different levels to it. So it's still a lot. I mean, I'm going to be talking for a while and there's going to be a lot of information on the slides, which, I'm fine if folks get a copy of it. So you don't need to like read everything right now. But as I said, it's still a bit high level here because there have been so many nuances, so many changes, and just so many different pieces that have had to be sort of pulled or waived or temporarily, postponed in order to make telehealth work as widely as it can in response to COVID. So a lot of your existing policy for telehealth pre-COVID and what a lot of the waivers and temporary changes dealt with was really centered around reimbursement. There are other things that impact telehealth, such as like prescribing laws, licensure, etc. But a lot of like what's on the books, what's established that specifically deal with telehealth, deal with how you get paid for it if you use it. And then that reimbursement policy can be divided into like 4 other elements. What, where, who, and how. So what service is going to be paid for if you deliver it via telehealth? Where's the patient located when the telehealth interaction takes place? What modality are you using when you are delivering that service? And who is the provider who's providing the service? So you'll see if you look at a piece of telehealth reimbursement policy, it's broken down by these 4 elements, and there's usually some limitations, such as I'm a Medicaid program, I'm only going to reimburse for the service, telebehavioral health services, how is it delivered via live video, when the patient is in a hospital or a doctor's office, and when it's being delivered by a psychiatrist. So that's kind of like the basic structure of a lot of existing telehealth reimbursement policy. Now, before we dive into the federal changes, which are primarily Medicare, I do want to clarify 2 things here, or two sections. So Medicare policy related to delivery of health services with technology, it can be divided into two buckets. You have the bucket that's labeled telehealth, and then you have a bucket labeled tech-enabled communication-based services. Now, the telehealth bucket is considered the use of telehealth to essentially provide a service that you would have provided in person, or you could have provided in person. This is controlled a lot by what's in federal law. So if you want to change some of those elements in there and how it's being reimbursed, you actually do need to go through Congress to do that, because you need to make the change in federal law. So that's the telehealth bucket. Medicare a few years ago recognized, hey, technology has advanced so far, we're able to provide services that we actually don't really reimburse now. So there's not this one-to-one replacement for in-person and using of technology. And we're calling this category tech-enabled communication-based services. And they're not considered telehealth in CMS's eyes. There's this other category, even though they use telehealth technologies to deliver services. The reason I want to make this distinction is that they are treated differently. You have telehealth that is controlled by a lot of like what's in federal law, like it needs to take place in a rural area, only certain providers can provide it. But then you have this other category called tech-enabled communication-based services that's not underneath those same restrictions as telehealth. They've got other restrictions that CMS came up with, but they don't have those telehealth restrictions. The reason I'm spending so much time explaining this is because I think it's gotten a little confused during COVID, because they've been lumped together. And I think some people think when they are billing for some tech-enabled services, they think they're billing for telehealth, but in CMS's eyes, they're like, no, you're billing for these other services we're calling tech-enabled. And we pay them at a different rate too. So I have come across providers who've said, I've done a telehealth service via telephone, a telehealth consultation, and I only got to pay $10. And I asked them, well, what code did you bill with? And they gave me a code that was actually a tech-enabled communication-based code. So I said, that's not telehealth in CMS's eyes, it's this other bucket. It employs telehealth technologies, but it's not considered telehealth. It's got its own separate rules and also own separate payment structure. So I just wanted to make sure people understood that and like have that clearly separated out in their minds. So what were the changes in CMS policy? Now, this has been a combination of things that Congress has passed and that had a temporary effect. So it is federal law now, but they've specifically said for a lot of these changes that this is, during when a public health emergency is declared. So it's not like a permanent change. It's like during a change that goes into effect when something happens. And also administrative changes that, again, we're CMS, like we're able to do like on their own, or they have the power to like do this with the public health emergency. So a lot of the big changes we'll go over first are in those, what, who, how, and where type of buckets, elements that I mentioned earlier. So first off is the where. The big change, and one of the first changes they made, was the location of the patient, because before COVID-19, it had to take place in a very specific geographical area, which was a rural location, and there was a specific definition of rural, and it needed to be in a certain type of facility, usually a health facility. Home was allowed before COVID, but only for like a very narrow brand of services. That was end-stage renal disease, and then if somebody had been diagnosed with a opioid use disorder and a co-occurring mental health disorder, those services can also be provided in the home. But that was it. So what Congress did was, again, pass a bill and said that during the public health emergency, the secretary could waive the geographical limitation and also open up like, the site limitation. So that's what's gone into effect during COVID. Right now, the patient can be located in any geographical area, urban or rural, and also could be located in their home to receive services, which, really addressed the need that we had immediately with COVID. Location of the provider, not necessarily something, that was like sort of a rule, hard and fast rule or in statute pre-COVID-19, but there are always, questions of whether, the provider could be at home when they provide services, and CMS clarified that, saying that, yes, that can also happen too during COVID. Modality, the how of how you're delivering it. So for the most part, before COVID, it was like live video. There was store and forward available to telehealth demonstration projects in Hawaii and Alaska. Audio only was not allowed before COVID-19. But that's changed. So what they did during COVID was CMS has allowed some services, and I'll stress that, some services to be delivered via audio only phone. They have a list of services that they will reimburse. That's on our next slide. And then they have on that list, like, especially marked saying like this can also be delivered audio only as well. Now, in those communication-based services bucket that I mentioned earlier, you are allowed to use the phone in some of those areas as well, and for some of those services. That did not change. That was actually something you could do before COVID-19, and they like re-emphasized you can do that again. And I think that was again where some of the confusion came in, where people were sort of melding the two buckets together of telehealth and communication based services. So that's kind of what's changed with the modalities, that audio only phone is allowed, which is something that again policymakers recognize. Perhaps not everybody may have that connectivity or access to like a laptop or a smartphone from home. You still need to provide services to them if they're sheltering in place at home. The type of provider. So before COVID-19, it was a very limited list. It was like about 8 different types of providers: doctors, physician assistants, dietitians. A glaring omission from that list were federally qualified health centers and rural health centers, as well as a lot of allied health professionals like OTs and PTs. Again, the waiver was put in place, and CMS has actually now opened it up to all healthcare professionals who can bill Medicare. So that does include them. And Congress specifically said we're allowing FQHCs and RHCs to do this, at least temporarily during this time. So that has been opened up during COVID as well. Services, actually the number is up to about 240. So pre-COVID-19, there were probably about 100 different service codes that CMS said we will reimburse if provided via telehealth. They updated that list and they put on more codes, so it's up to about 240 now. Again, I believe you get a copy of the PowerPoint, so I do have that linked in that big here there where you just click on it. Also check that list because it really signifies exactly which ones can be provided by phone only. So it's not all the services can be provided by phone only. It's only the ones that they have marked saying audio is available for it. So the fee for service is still the same rate you would have received had you done the service in person. However, if you are an FQHC and RHC, you will not get your usual PPS or AIR rate. For those who are not familiar with that term, so federally qualified health centers and rural health centers, they get a special rate based upon this methodology and calculation that they have, and like all that they do within their scope. And sometimes it may be, for some, it may be higher than $92.03, or maybe lower. So why they get the specific rate and not what they would usually get is because that was actually in the congressional bill that allowed them to become a distance site provider. Congress said they're going to get a rate that's going to be based off of the physician fee schedule rate for fee for service. And there's this calculation, which I'm actually not sure what calculation CMS used, but the number they came up with was $92.03. So if you are an FQHC and an RHC whose rate is typically under $92.03, you're okay. You're going to get more if you use telehealth, but if you typically get more, that may be a little bit more of a problem for you. Modifiers, I'm not going to go too deeply into that. It's fairly self-explanatory if you're fee for service, a little bit more complicated if you're RHC and FQHCs. And I will talk about RHCs and FQHCs a little bit more in detail. So I'm just going to like go through this really quickly. Now, those were kind of like your large telehealth like obstacles. And as I said earlier, telehealth policy can kind of sometimes be like an onion. So you peel away the first layer, which had all the big things like the geographical limitations, what type of services are able to be paid. But then you find yourself hitting another layer because there may be other things where, could kind of impede your use or influence how you use telehealth, or could be a way that you could have been providing services, but they hadn't considered using telehealth before. So some of these are examples of some of the other changes CMS made for Medicare that fell into one of those categories. Was like, oh, another thing that wasn't one of those huge policy changes, but was still like, an impediment possibly, or disincentive to use telehealth for some reason, or was like something that they hadn't considered using telehealth before. And said like, you know what, this is actually like a pretty good tool to use during this case. Why don't we just like make it available? So first off, dialysis patients, for dialysis patients, they have a requirement under CMS that they need to have a certain number of visits face to face. Dialysis patients, really vulnerable population during COVID. So, to minimize their risk, CMS said, well, instead of having them come in the clinic to make sure they have the face-to-face, why don't we just do it over telehealth? So they allow telehealth to be used. That's one of those cases of like, oh, we hadn't considered using telehealth in this case before, making it available to it, but why don't we, especially now if we're trying to like minimize people's exposure and their risk? So that was like one of those cases. Hospice, again, something like that. It's like to see if like you can continue hospice or able to continue hospice, you have to have that face-to-face meeting. Again, they're saying, let's just use telehealth and make that available to it. Now, this is one of those quirky things that, could be an impediment to the use of telehealth, but it was actually a rule CMS had in there in that, before COVID-19, if you were a provider, you had to put the address of where you were located when you did the telehealth interaction. And for some providers, they may have been at home. They said, I don't want to put my home address on because that's actually publicly accessible information, those claims, and people are going to see where I live, have my address. So that was like acting as sort of a disincentive maybe for providers from using telehealth because they're like, you need to put your home address. They didn't want to. So CMS said you don't have to do that during COVID. If you're like associated with a clinic or a hospital, you can put that address. So again, like one of those policies that weren't like a statutory requirement maybe, but like could act as an impediment, wasn't necessarily there to like inhibit telehealth, but could inhibit telehealth, that was like waived or addressed during this pandemic. Two interesting things with like hospitals and originating site fees. Again, just like one of those odd things that kind of happen just because of like the situation we're in now with COVID. They're allowing hospitals bill an originating site fee when the patient is at home because there are cases, obviously people are sheltering in place, you're trying to minimize their contact, and then also if it's not serious, you kind of don't want them in the hospital during this time too, when maybe, personnel and the resources of the hospital may be taxed. So, hospitals were using telehealth to do something like that outpatient care rather than have the patient come in and the patient was doing it from home. Well, the problem with that is that the hospital is still doing like a lot of that administrative work too, which they normally would have gotten like a facility fee or originating site fee to like cover that cost. But they're not getting that now because the patient's at home. So the hospital's saying, we're still like, these are still expenses we're expending. Can we get the originating site fee? And CMS has said, yes, for this case, we will. And also for some of the remote outpatient therapy and education services, they're going to allow them to use telehealth as well. So it's because of this unique situation. Hopefully it's unique because I would hate to see a repeat of it, but the situation with COVID that have brought up all these scenarios, CMS has made adjustments to try to alleviate the burden on healthcare providers and ensure that there's some type of reimbursement if they use telehealth. A couple of other things, it's removal of frequency limits. So there were, again, these are like more of a direct barrier, not necessarily required by statute, but saying like, oh, you can only use telehealth so often. Like for in a skilled nursing facility before COVID, it was only like one telehealth visit every 30 days, that type of thing. They were saying like, let's just remove those. And like during COVID, you can use it a lot more often where we're not going to have these frequency limitations. So start clause. So sometimes start clause can act as sort of an issue for telehealth programs, although there are a lot of safe harbors and exceptions to make sure you don't violate start clause, because a lot of people were ramping up so quickly for to use telehealth. Congress realize like, let's provide like a little bit of flexibility for folks and like, waive some of like those more sort of restricted things in order to allow people to ramp up quickly, instead of like, like saying we can't ramp up that fast because we need to figure out which exception we might fit into start clause. And then supervision, again, one of those, allowing telehealth to be a tool to use in order to like kind of like have more expansion or greater like capacity there. So like using telehealth to provide supervision and ensuring also some providers were able to practice at the top of their license because there may have been like some sort of issue with like supervision or something that kind of like, may have limited them because they may have were told that they needed somebody specifically physically there instead of being able to be supervised via video. So those are just some of the changes. Like I said, this is very high level. There's still actually a lot more. I think somebody said there was probably about 35 specific changes. I actually have not sat down there and counted up all the changes. And you can see I only went through a portion of them, but it can get very detailed and very nuanced. What's down below are links to some of the CMS resources that you can follow up on, look at what I just covered, or also some of the other ones that I have left out of this presentation. Now, I did say I would get a little bit deeper into the FQHCs and RHCs and what they're allowed to do. So again, for folks who may not be as familiar, FQHCs and RHCs were not allowed in Medicare to act as that distance site provider. They could not provide services via telehealth. They could act as an originating site, like the patient could be located in FQHC and RHC when they receive services via telehealth from somebody else. But the FQHC and RHC could not act as that distance site provider. Very problematic during COVID because people weren't coming in the clinics, they were staying at home and they were like trying to get services via telehealth. So Congress said that during this emergency situation, FQHCs and RHCs can act as that distance site provider. Problem is, they hadn't been able to do that before, so CMS had to figure out, well, exactly how are they supposed to do this? How are they supposed to bill? What do they need to be aware of? So CMS came out with like their guidance on like FQHCs, RHCs, this is what you need to know. And we'll go over some of that now. So basically, what modality were they able to use? And essentially, it's kind of like the fee-for-service. It was audio only and video telecommunications technology. They are, excuse me, they are allowed to use phone only, but again, they're limited to those services that CMS has specifically said are audio only. And they are allowed to use some of the communication-based services too. Not all of them. Not all of those are available to FQHCs and RHCs, but they are allowed to provide some of those. Excuse me. What provider in an FQHC and RHC can provide services? It's basically any healthcare practitioner that's working there, as long as they're working within their scope. So they can be actually that telehealth provider. Can the practitioner furnish services when they're home? Because, the whole, for those who are FQHCs and FQHCs, the whole four walls issue and saying like, oh, do they need to be in the clinic when the telehealth interaction takes place? And CMS has said, no, they can be at home. Again, to make sure that, the greatest possible flexibility is given. So they said the provider can be at home when the telehealth interaction takes place. What services can be provided? This is where it kind of got a little confusing for FQHCs and RHCs, because FQHCs and RHCs have a scope of work, so they're used to like only providing certain services because that's within their scope of work. That's what they're supposed to do. But then CMS came out and said FQHCs and RHCs, you can provide all the services that we said are okay to provide. So that has caused a bit of confusion, I think, for some FQHCs and RHCs, because they're saying, we're supposed to act underneath our scope of work, and these are the only services we're supposed to provide, but CMS is saying we can provide the whole list here. So I think probably maybe just go, not legal advice I'm giving you, but CMS has said that they will reimburse for all the services if you provide them and bill for them. So that has been CMS's direction there. Will you get your usual rates? And the answer is no. It's going to be $92.03 if you use telehealth to provide the service. And then there's like a couple other things here. I want to make sure I can get through the rest of the presentation. But the wraparound payment, would it apply for this? And it's like the answer is no wraparound payment for distance site telehealth services adjusted by the MA plans. For co-pays, they were saying for when it's COVID related for testing, you have to waive the copay, but it looks like you would have to get it for everything else that you typically would. But they do say use the CS modifier on the service line when you're doing that waiving of copay for COVID. Will the cost for providing telehealth be used to determine PPS and error rate? And CMS has said no, but then gave you specific instructions on reporting. And then they were asking for informed consent. Telehealth, there's actually not an informed consent requirement, but there are for some of those communication-based services ones. So they did say that, you still have to abide by that, but you can do it at the same time the services are being furnished. So a little bit of flexibility as to the timing of getting that, but still seems to be the requirement that you need to get it. Billing, this is where it gets a little tricky. So my understanding of this was CMS really wanted to make sure that FQHCs and RHCs had the ability to start billing, and they wanted you to start billing, but they couldn't quite get their system up to speed immediately. So they were saying that if you provided a service via telehealth from January to June, RHCs use the code 2025 with a modifier CG. Your error rate, what you get with your error rate, it's going to look like you're getting your error rate. You're not actually getting your error rate. They just couldn't get their system up or changed in order to reflect the $92.03. So it's going to look like you get your error rate, and they will either recoup the money if you typically get more than $92.03, or they will give you more money if your actual error rate is at below $92.03. And then starting with July 1st, they said that they should have their system all fixed and able to like do all that calculation and like accurately reflect what you should be getting as your reimbursement. Um, and then you don't need to use your CG modifier after that either. So those were the instructions they gave out. And yes, it's a little bit, cumbersome and a little confusing, because he's like, oh, yeah, I get this money, but then you're going to take it back if I happen to get more than $92.03. But they simply, could not get their system changed in time, is my understanding of the reasoning behind all this. But RHCs, you kind of have a little bit better than what the FQHCs had to go through. So FQHCs, they wanted them to build 3 codes for that January to June period. So that was a little bit more complicated for them. And then it kind of gets easier for them once starting July 1st. So this, again, it's a little bit cumbersome, but I think we have to understand that we are talking about large institutions trying to move very rapidly, and they just could not get it changed until July 1st. So that is like the very complicated billing, but hopefully it wasn't too cumbersome or too difficult for people to go with that. We are in July now, so theoretically they should have like the system in place now where it's a little bit easier to bill, and a little less confusing. I have not heard anything about people running into difficulty on that, but then again, I may not I'm just not aware personally. Nobody said anything to me, and I haven't heard of CMS saying delay this because we couldn't get the system in place yet either. Virtual check-ins, technology-enabled communication-based codes. So these are those codes that I was talking about that CMS don't consider telehealth, but use telehealth technologies and what they are. These, like I said, were around before COVID-19 hit. So they've been actually, some of them been around for a couple of years. The only thing they really added during COVID-19 was some online digital evaluation codes, but this was like not really changed. And some of these services also allowed you to use phone to do them. So your virtual check-in code allowed you to use phone to begin with. So that was always an option there. Now, this is where I think some of the confusion happened and why I spent so much time at the beginning of the presentation making the very clear distinction between this. Because I think when CMS started allowing phone to be used to provide services via telehealth and reimbursing them for that way, some people were billing the virtual check-in code here, which does allow you to use phone, and they were wondering why. They said, I did a consultation via telehealth and I only got $10 for it. I thought I was supposed to get paid my usual, what if I had done it in person type of fee, which let's say was $50. When I did a little probing and I asked them, well, what code did you bill? And they said, oh, G2010. And I said, oh no, that's the virtual check-in code. That's not considered telehealth by CMS. So that's why you got paid $10. And I think that got a little bit confusing for folks, where they were thinking they were doing telehealth, and then but they were really billing underneath, in CMS's eyes, these technology-enabled and communication-based services. This is also very important because some of the states are saying, like, we're allowing audio-only telehealth as well, but what they're saying to bill is like these virtual check-in codes, the G2010 or 2012. So be careful about that. They're saying telehealth, but what they mean is this, and then people build that and they wonder why they only get like such a small amount of money. Because the virtual check-in codes were literally what it's called, a virtual check-in, quick check-in. They weren't meant to be paid a whole lot of money. FQHCs and RHCs, I said earlier, they're allowed to bill some of those communication-based codes, and these are the ones. The rate that they get is $24.76, no matter which code they're billing. It's not all of those codes that were on that previous slide. It's only these that I mentioned here, and they get $24.76 flat. That's it. One thing I want to point out, so one of the sort of processy things that CMS said in regards to telehealth. So usually when CMS is deciding what service to reimburse for, if you deliver it via telehealth, they go through this regulatory process. Probably some of you are familiar with it. It comes out. So what they do is when they consider adding new services, either CMS comes up with the idea themselves and says we're adding this code, or they get from the public a recommendation of a code. So when they get that, you're supposed to submit evidence to it that it's like, effective to do this, etc. And then CMS would consider it. It goes through this regulatory process, usually through the physician fee schedule, where it's published in the Federal Register. They take comments and then they make a decision. CMS has said during COVID, we're bypassing that process. So if there's a code that you think that CMS Medicare typically reimburses for, and you think it can be delivered via telehealth, and it's not on that list of 240 codes, send that into CMS. They're saying, like, we're not going to go through the regulatory process during COVID. We're just going to look at it. If we think it's okay, we're just going to stick it on the list. So that's a little bit of an easier way of like trying to get a code that you think, a service that you think can be delivered via telehealth, get it approved than the usual process, which is a little bit longer and can actually be a little bit more difficult. Right now, they're just saying, we're just going to evaluate it really quickly and not go through that regulatory process. So just wanted to point that out there in case there was something that CMS missed with their 240 codes that you think can be delivered via telehealth and is something that CMS is already reimbursing. States, what are they doing? So before COVID-19, you had all state Medicaid programs reimbursing for something via live video, at least one thing. Story forward and remote patient monitoring, a little less popular, and usually they were like, it was very specific, a lot of caveats, such as remote patient monitoring was like usually for a chronic condition. Now that's important to note that that is like such a low number. It's not quite half the states, because for most of the Medicaid programs, when they said the home was an eligible site, they were thinking of remote patient monitoring. So if they were thinking of that, then they were just limiting those types of services that could take place in the home. So that was your situation before COVID. What you also had, though, going on with states were private payer laws and like how commercial payers are supposed to handle telehealth reimbursement. And you had laws that ranged from, a state saying health plan, you can cover telehealth if you want to, all the way to a state that may say health plan, you will cover telehealth delivered services the same way you would have in person. And oh, by the way, you will pay them the same amount. And then everybody else kind of falls between. That was also going to determine sort of how much say a state had over a commercial payer during COVID, saying like, you're going to cover telehealth during COVID, by the way, or, they were saying, or you may have had states with maybe like less oversight because of the way their laws were structured, saying like, we encourage you to like cover more telehealth delivered services. So that like influenced, how much of a mandate could have been put on health plans in a state. So what we saw on the state level, a lot of the common policy changes were very similar to those that we saw on the federal level, in that the eligible originating site, states for the most part didn't have geographical limitations like Medicare did. But what you did have was like not as widespread allowing the home to be an eligible originating site. That blew open during COVID. That was like the number one thing that states were saying, like, we're waiving that. We're temporarily waiving that and allowing services to take place in the home. Very logical, so not a surprise. And then they also did follow the route of allowing phone, again, because not everybody may have access to the technology or the connectivity. They're saying you can provide services via phone, but again, be aware when they say that, some of the states may have been saying that we're allowing you to use the G2012 or G2010 codes, and that's not quite telehealth, or if they're calling it telehealth, it's still not going to pay you probably what your typical amount would be had you done like an office consultation or something like that. So just keep that in mind. And then requiring health plans or managed care plans to cover telehealth and offer parity, again, would depend on like how much oversight or power that they had in the state, with how their statutes are structured, on how far they went with that with health plans. And also, to be fair to health plans, a lot of them just decided on their own to cover telehealth without being ordered by the state. So that did happen as well too. Less common telehealth policy changes, expanding the modalities beyond like allowing phone and audio only phone. So there were some states that did this, but not a lot of states said, oh, we're going to expand remote patient monitoring, or we're going to allow more storm forward. That was like a less common policy change that we saw. Expanding the list of eligible providers, this was kind of like mixed bag. The sort of like most immediate sort of providers that you saw being added to the eligible provider list were your allied health professionals, PTs and OTs. There were actually, Medicaid programs, unlike CMS, that already allowed FQHCs and RHCs to be distance site providers. We saw some expansion of that, but again, it wasn't like a widespread expansion. And then consent requirements. So a lot of states actually either in law or within their Medicaid policy had some type of consent requirements. We saw sort of adjustments to that where there were places of like written consent was required. They said like, well, oral was fine to have as well. So some relaxation of those. So where are we going in a post-COVID-19 world? So what people are worried about now is the cliff effect, which is, hey, the public health emergency is declared over, nothing's changed, we revert automatically back to pre-COVID-19 telehealth landscape. And what happens to all the investment people made there? What happened to the consumers who have gotten used to telehealth? They want to avoid that very sharp, drastic cliff effect. So, executive orders and waivers are starting to expire, or like, maybe are being considered up for renewal or something. So they're trying to get things in place. They're trying to like align their ducks to avoid that cliff effect from happening. We're seeing a couple of things that are going on. There have been like, a few federal bills that have been introduced to try to like make some of these changes permanent. The Senate Health Committee did do a hearing on this. We know at least federally, the public health emergency will be extended at least another 90 days. One thing that I think people need to keep their eye on, we've seen the first step on this. There are some changes that CMS can make administratively, so they don't need to go through Congress. And we saw the first sort of like making permanent one of these COVID changes, and that was in home health. Home health, where they have gone through the regulatory process. So they did issue or submit a something for the Federal Register, a proposal to change the regulations on that. So that's your first step, the first time we're seeing of making some of these changes permanent. The home health one was not a huge change. It was something like included in the telehealth in the plan, etc. But that's that first step, and probably where we'll see like indication of what is likely to stick around, because the physician fee schedule will usually come next. It usually comes out in July. And that's like, the plans, the proposals that CMS makes for Medicare for the following year. So I think what they're able to do administratively, they'll probably like stick in that physician fee schedule. So we'll get an idea probably in the next couple of weeks or so, or any day now, basically, when that comes out, of what they might try to do on the administrative side as well. Secretary Azar, I believe, came out yesterday and said on a webinar, on a talk, where he said that, HHS is committed to working with Congress and trying to make these things permanent. Some things will need to go through Congress. So that FQHC, RHC acting as a distance site provider, that actually needs to go through Congress. So some of those things will require congressional action, but I think with something like the physician fee schedule, we'll see what CMS will be able to do administratively, like what those changes. One of those things is like, keeping that expanded list of services, keeping all 240 on that list still as available as being using by telehealth. So, and then there are a couple other things that they may be able to stretch out administratively and do without congressional intercession or interference in, or help on. What are states doing? We're already starting to see states making some of these things permanent. So they're either doing it administratively through their Medicaid program, or we're starting to see it like in bills. A thing that a lot of them are struggling with, I think, both on many levels, is like, do we want to consider using audio only, keeping that around? So before COVID-19, a lot of jurisdictions on the state level excluded phone from their definition of telehealth or telemedicine, depending on what term they were using. So the question is, do we keep it around now? Do we incorporate it into our definition of telehealth? And then the other question is, should it be paid the same amount? And that's something that's being debated and examined right now too. So I don't have any specific answers for you. I just know that people are raising these questions or asking these questions now. A couple of things of resources that I thought were really interesting. So California did a consumer telehealth website. This is put out by the governor's office. It's it's a consumer website. It has information on what is telehealth, where you can like get some information and so forth. But a neat function that they have on here is a consumer can type in their zip code, and it'll bring up all the health plans that service that zip code and link the consumer to the telehealth policies for the health plans. Now, those telehealth policies vary like how great the information is, because that's the health plan set it up and not the state. But this was like a really neat search function that I had not seen anywhere before, and definitely not done by like a government, that I thought was really great and just wanted to make people aware of. In other states, if you want to do this, this might be like a really great tool for your citizens. The other thing is HHS also did a telehealth website, again, for information for patients and providers. That was really nice to see as well. I do know that they are very serious about like, keeping this updated. So that's also like a good resource for folks as well. And then just some of the CCHP resources that we have available too. And I think that is it. Questions?
Awesome. Well, thank you so much, man. I'm going to give you a second so you can take a sip of water and breathe some air because we do have a lot of questions in the chat. So I'm actually going to go in order, since I don't think anyone has seconded any of the questions. So I'm just going to go in order of questions. So the first question is, our Regional Telehealth Alliance is interested in learning your suggestions about how to best advocate to our state Medicaid agency for the continuation of COVID-19 relaxed regulations for telehealth reimbursement and access coverage.
So I would say first off, let me clarify, CCHP does not lobby. My HRSA program officer is on here. We don't lobby. But what we have observed as being useful is, I don't know who is in your telehealth regional alliance. I would suggest you get as many partners as possible, and different partners. Don't limit yourself just to healthcare folks. Think of like other folks who may not be your usual suspects. I mean, I think probably some people, when they think of a telehealth group and partners, they go automatically to your usual suspects as like the hospital association, the primary care association, the medical association. But there's a lot of groups out there that are extremely interested in telehealth, such as like consumer groups, such as like AARP, or groups with children with special health care needs, and like just different other allies that I think would be useful. And that usually presents a very powerful voice when you go and talk to either the administration or the legislature, and that they recognize that this impacts a lot of people. You have like this whole group together. So that would be the first step of like, what I would say like would help with your advocacy, is like have this very diverse group of partners that you work with. And also, the benefit of that is like you have this diverse group of partners that you work with. You also start minimizing like maybe opposition when something does come up, because you've already spoken to them. They kind of understand where you're coming from, and they either start going neutral on you, or they may support your cause as well. Now, if you are talking to a Medicaid department, it's going to vary. I don't know what state you might be interested in, but it's going to vary. In my experience, Medicaid departments vary. Some of them are very open and very communicative, and then others have like a lot of layers of bureaucracy where it may be kind of hard to like, break through some of that. I would say your hardest task, and this may be kind of impossible because this person simply may not exist, is find who is the telehealth person there at that department. And I'll be honest with you, they may not have one. So then your next step is to go to like, who is probably in your policy sector, who like looks at policy for that department as well, and get to them and engage with them on it. What they are going to look for when you go to and talk to them, they're going to look at, I'll be honest with you, they're going to look at, is this as good as in person, and how is it going to save me money? Because they do need to keep in mind the fiscal considerations, and those are two things that they are very interested in. So if you can get your education and materials together, that's the best way of doing it, saying like, yes, it's effective, it can do this, and we've looked at it and it could save the program money as well.
Thank you, May. I know we have 8 questions and 7 minutes left, so we'll go through the next question. So the recent CMS announcement regarding making home health flexibilities permanent locks in a financial system that penalizes blended visits, such as in-person with virtual follow-up. Should we worry that this is a harbinger of things to come, expanded options, but a steep financial disadvantage to in-person?
That one I can't say, to be quite honest. A lot of times quite frequently, I don't understand the thinking sometimes on decisions made, or I mean, I can guess, but they don't consult deeply with me, so I may not understand like the steps that they took reasoning. So I don't know if that is probably something we should be worried about. It could be, and I would say it may not only be CMS, but you might also watch your state programs as well, because remember, they are operating on 2 levels, in some ways connected, but in other ways not. So connected in that when CMS does something, you may have it replicated on the state level, but even if CMS doesn't do something, the state level may go a different route too. So I'm sorry I couldn't give you a better answer. It is just something to be watchful for.
Thank you. Can you talk about hospital outpatient settings being able to bill for ES telehealth? Can they bill for originating and distant site fees? Also, can you talk about RNs and pharmacists not being able to bill Medicare except in hospital outpatient settings?
I think so. I'm going to take the second half first if I'm like understanding that. So I think the reason why RNs and pharmacists can't bill is like, are they able to typically bill Medicare is the question, because I think we've had this question come in through our one of our TAs, and we looked it up. I might have to get back to you because the RN pharmacist, because it's reminding me of a question that I just saw recently that came in. On like whether they are typically allowed to bill. I'll be honest with you, I know like the list for pre-COVID-19 list. I don't know of like who's an eligible provider. I don't know what all the eligible providers for Medicare are who can bill. So that would be the first question, is like, first off, are they an eligible provider typically in Medicare where they can bill Medicare and get reimbursed? Because what Medicare said for the telehealth policy is like anybody who is an eligible provider who can bill Medicare can use telehealth, falls one of the services within their scope to like bill these services. So if they're not typically eligible to bill Medicare in the first place in person, regardless of telehealth in person, then they're not going to be able to do it via telehealth. Now, talk about hospital outpatient settings being able to bill for DSMES services. Can they bill for originating site and distant fees? So I think that was with that section with hospitals that I was talking about. My understanding of like how they do that, it's when the patient is now at home now, and this was typically like an outpatient service they were billing, it was the provider who they saw would be billing as the telehealth provider and will get that fee, and then the hospital now is allowed to bill like their originating site fee. So I don't think necessarily the hospital is billing both the distant site and originating site, if I'm understanding the question of like what they're getting at. But we could take that back and like delve into that a little bit deeper. There is on one of my slides, we have like our email address if you want to send that question to us, and with maybe a little bit more detail so I make sure I'm understanding it correctly, we can try to answer that to you, after the webinar.
Great. And I think we have time for just a couple more questions. The next one is, if the geographic restriction is permanently lifted, will the definition of MUPs be changed to include individuals based on social determinants?
I'm not sure if I really understand the question, because if the geographical limitation is lifted, then that basically that was talking about the location of person, and that means like everything would be available as long as it's within the United States, I think is the one of the sort of like requirements. So I'm not quite sure what the definition of MUP might have an effect on it. I mean, unless Natasha, do you have like insight on that?
Unfortunately, I don't. Yeah, the question itself is a little tricky, so maybe we can
Yeah,
come
because
back to.
I'm not, I'll be honest with you, I'm not seeing the connection. If the geographic limitation is lifted, then I'm not quite sure what the definition of MUP might have to do with it. But again, another thing we can like look into just to make sure I'm understanding the question correctly.
Okay. Yeah, we could definitely go back and ask the person that asked that question and follow up with them.
Okay.
Yeah. So I know there's a few questions left, and I know, Reed, I think we have a way to get back to the folks that asked these questions, but I think the final question will be the FQHC specific question. Our members are concerned about billing expanded providers and services to telehealth because of the cost reporting. We know CMS said cost reporting doesn't apply here, but we need more clarification to feel confident. Can we hope for clarification?
Um, do you need clarification maybe from HRSA? Is that where you're hoping for clarification from?
And I think on the like the second part under that, it says cost reporting doesn't apply to setting PPS rate, can't correct an already submitted. Okay. I think these two things were kind of aligned here.
Can't
Maybe that.
correct an already submitted. Okay. Cost reporting doesn't apply to setting PPS rate. Are you hoping, but are you hoping for a clarification? Because this was CMS saying that cost reporting doesn't apply here, was the questioner asking about clarification from, I'm not, are they asking for clarification from HRSA on like?
So the question, sorry, I wish I could have edited my question because I didn't enter it the way I meant to ask it. So we know that CMS said that the cost reporting for telehealth wouldn't go towards PPS rate, but our FQHC members have a lot of questions about how to appropriately record that cost reporting for telehealth, including how do you calculate how much time is going towards the visit? What does that mean when it's spread out, not all in the room with the patient? We were hoping that CMS would follow up with an additional clarification on how to do cost reporting for telehealth, because when we look at the guidance they have and send us to, it simply says this isn't relevant to FQHCs because they are not distance site providers. So as we get into areas like now we've got a novel list of services and providers who can be providing it, plus this new mode of delivery, and we're supposed to do the cost reporting for informational purposes, there's both confusion over how we're supposed to do that and also concerned that down the road, this is going to affect our either our PPS rate or whatever becomes a telehealth reimbursement rate, and feel a lack of confidence in what we are reporting correctly. So I didn't know if there's any way to know what CMS will be offering additional guidance on. Is this all we get? Are we waiting for Godot here, waiting for them to give us more guidance?
Hopefully you're not waiting for Godot, but but I said hopefully not, but it may be. This is actually a conversation I've had with a couple of feds saying that I think we're getting the sense that FQHCs may, not only with Helen, this particular question you raised, but possibly with other things as well, like a little bit more clarification on what FQHCs, would need to know. I haven't received an answer on like, is anybody coming out with anything, to be quite honest. It's been raised to, I think, HRSA. I've talked to a couple of people at HRSA, and it's definitely been brought to CMS. But I have not heard of them issuing another guidance. I hope they would issue more information, but I haven't seen anything yet. And quite frankly, I see it when the rest of the public see it. They don't consult with CCHP, so I don't have like any inside track on if they're thinking of it or if like, something's coming out, imminently coming out. So all I can say is it's been raised. The specific one, this is the first time hearing it. So this specific one, I can take it and try to like, raise it up again. So try to get it on as many people's radars as possible. But I have not heard of any sort of, rumor or any news of like, oh yes, there's going to be like another FQHC guidance update. Actually, I looked at that FQHC guidance just like yesterday afternoon, and it was updated with some information. I don't think related to this, but it was updated for July 6th. So they did do a little bit of updating to that. So yeah, they're kind of doing some things, but I have not heard of this specific question being addressed. It was actually not something on my radar either, but if folks would like, I can try through my contacts just to try to get it on some people's radars, and we'll see what happens.
Great. Thank you so much, May. And I think that we'll go ahead and conclude today's session. I know there were a few questions that were not answered, but I'll work with Reed on how to answer those questions. But I did want to send a reminder to folks to please submit your session feedback within the Event Mobi app. We rely on the feedback from attendees at these sessions. So thank you so much for coming to today's session. And if you have further questions, I think May provided her information. You could always contact CCHP directly. And with that, I'd like to thank May and the Northeast Telehealth Resource Center and the Mid-Atlantic Telehealth Resource Center for their work today. And have a great rest of your afternoon and happy Friday.
Thank you, everyone. Bye.